This court is now in session. Please be seated.
Your Honor, for the purpose of the record, we return back to the trial of Commonwealth versus Lindsay Clancy. All parties are present, including the defendant and the 18 jurors.
All right. Thank you. Mr. Reddington.
If you would just please look at your medical records that you have in front of you, I believe, and just go back to the October 20th record, where you have, I believe it's called interval history.
I had trouble hearing the date. Can you repeat that?
Sure, October 20th. Sorry.
Okay.
So looking at the interview history, that's when that you decided to start Zoloft. It says a week ago, right?
That's when the patient started it, yes.
Okay. And she then increased the dose, and it says last night, right?
Yes.
And what was she telling you on the computer screen when you were talking to her? What did she say about increasing the dose of the Zoloft?
That she felt awful. She couldn't sleep. Had insomnia, which became worse when she increased the dose. She didn't want to eat. She was having diarrhea. Food felt really unappealing. She was more depressed on it, crying all day yesterday, which is not normal for her. She had some mental fog and was terrified to start something new.
Did she also tell you about her anxiety level?
Anxiety was really bad even before med. Now, hard to differentiate. Overnight, racing thoughts, paranoid of getting suicidal thoughts, something bad happening, doesn't want to be alone.
That must have given you concern that you had a pretty sick patient on your hands at that point, right?
I was concerned, yes.
So you gave her some therapy, did you?
I gave her some therapy in conjunction with discussing all of her symptoms and assessing her and managing the medication.
Okay, and again, I apologize. You have to keep your voice up so people can hear you way down here. So when you say that you were talking about the symptoms, and what did you do? Just talk about the same thing that we've just gone over, the symptoms?
There were a number of them to discuss in more detail. That's the summary of them.
Okay. So did she discuss it in detail?
Yes.
Did she tell you that her symptomology at this point on October 20th was so bad that she had to have her mother come and stay with her?
Her mom was coming to provide support, yes.
She wasn't coming to provide support. She was coming to stay with them, to live with them, wasn't she?
Yes, I don't know for how long, but yes.
Did you bother to ask her? Why is her mother having to stay with them?
Because she needed some help.
Do you know how long her mother stayed with her?
I don't.
Do you know that she ended up sleeping in the basement?
I don't.
Do you know that she ended up sleeping with her mother?
I don't.
So you decided that you'd stop the Zoloft and you would monitor closely, right?
Yes.
What does that mean, you'd monitor closely?
Well, I saw her the next day, so that's monitoring, an example of
Okay.
monitoring closely.
So this would be on October 21st that you saw her the next day, is that correct?
Yes.
Now, on the 20th, you made reference to the fact that you also recommended that she try fish oil and things of that nature, natural remedies.
Yes.
Okay. You also wanted to look into what's called Zulresso, Z-U-L-R-E-S-S-O.
Yes.
What's Zulresso?
It is a treatment for postpartum depression.
And when you say that you were looking into it, what did you do? Did you find out if it was available and if she could participate in the program?
I did some digging online to see where it is done and how to do it. I hadn't officially recommended it, so I had not started that for her. It's not really an easy medicine that I could just start.
It's not a what? I'm sorry.
Sorry, it's not a medication I could start on my own. It is it's infused through an IV in a hospital, so it's a bit difficult to coordinate.
It's a 60-hour infusion, right?
It's a long infusion, that sounds right.
And it's about 2.5 days of infusion, and it has to be under hospital circumstance, and the only hospital around here is in Rhode Island, right?
Yes.
And did you ever recommend that she do that?
It was something to consider. I couldn't make the official recommendation because that's not something I prescribe.
Why?
Because you can't pick that up at the pharmacy.
Well, no, obviously you have to go to a hospital setting and basically have an infusion through your veins for 60 hours or 2.5 days, but why didn't you look into it or recommend that she do that?
Well, I did look into it.
So what happened?
She ended up actually going to a partial hospitalization program at the hospital that does it. I don't believe the program was completed, but she went. And I advised her to discuss it with them because they have access to that medicine. I don't have access to it.
Of course not. Is this Women and Infants Hospital in Rhode Island that you're talking about?
Yes.
So when you looked at the medical records for Women and Infants Hospital, did they make reference to your inquiry for Zulresso?
I never received records from women and infants.
Did you ever look at them or even online?
Online?
Yeah, like online, like you do when you talk to patients.
No, I never had access to them.
Why?
It's similar to South Shore. It's a completely separate hospital that I don't have access to. I don't work there.
Well, of course you don't work there, but you're a doctor and you're treating a patient who's got medical records that you could access through a HIPAA release, right?
Yes.
Why didn't you do that?
Well, she didn't ultimately end up having any treatment there, so it didn't seem necessary.
She didn't end up having any treatment there, so it didn't seem necessary. You can't just walk into that place and say, hey, I'd like some Zulresso, can you?
I don't exactly know how it works.
And then again, on that date, which would be October 20, when the jurors are looking at the records, you checked off the boxes again on objective findings, mental status exam, appearance, speech, things of that nature, correct?
Yes.
Excuse me for 1 minute, Judge, jurors. So when she was telling you on that date that she was in quoting your records, paranoid of getting suicidal thoughts and something bad happening, doesn't want to be alone, what did she mean by that?
Well, those were a lot of her words.
Right. Isn't that a concern? Your patient is telling you she doesn't want to be alone. Why didn't she want to be alone?
She was very anxious and had the feeling like something bad might happen.
Okay. Did her mother ultimately and dad come to stay with them?
Yes.
How long did they stay with them?
I don't know.
Did you, when you talked to the mother and the father, did you say to them, what is she doing? How does she appear? Is she in bed all day? What did they tell you?
They never called my office, so I never spoke with them.
They never called your office?
They never called me or sent a message, so I did not have communication with them.
So that's their fault that they didn't call you, the doctor, I guess, right? So, do you think maybe it would be reasonable if you're the doctor and you're investigating your patient's symptomology that you might, when you know that the parents are staying with her, that you would make a phone call yourself?
It's not typical when you have an adult who was able to advocate for themselves, to speak with their parents.
So while she is telling you about her symptomology and tearfulness and crying and unable to get up and anxiety and the medications and the mental illness that she had, you felt that she could advocate for herself?
Yes,
Okay, on the television, on the computer.
yes,
The next time you saw her was on October 26th, is that correct? And you can pull up your record.
yes,
Now, and if you look again at the interval history where you put down what's going on in the patient's life that time, this is when she indicated that she's back to where she felt that she was before Zoloft, which was not great, and that you guys were considering a new medication. Is that right?
yes,
And then you started her on Ativan, as we talked about, right?
yes.
And then you started her on the buspirone, right?
Well, she had already been started on the Ativan, and then we added the buspirone.
So my question was, you started her on buspirone, right?
Yes,
Okay. And also you added hydroxyline as needed, right?
yes,
And you continued the Ativan, correct?
yes,
Did you discuss side effects with her at that point?
yes,
Did you also discuss starting Remeron or pregabalin?
yes.
What did you tell her about Remeron and pregabalin?
I don't think I went into any detail about those medicines, just that those might be things to consider in the future.
And then you saw her on October 31st, right?
That was her, I think that was just a therapy appointment with a different provider.
Would that be Jennifer McAllister?
Yes.
So it's a different provider in the sense that she works for Astor, right?
Well, yes, it just wasn't myself.
Right. So on October 31st, they did a suicide assessment, or she did, right, McAllister?
I wasn't there.
Well, I know you weren't there, but these are medical records that have been introduced into evidence that the jury's going to have in the jury room.
Objection, is that a question?
No, good. Next question.
McAllister did a suicide assessment, apparently, right?
I'm sure she assessed.
No,
for
no, no. Look at the
suicide.
record, please,
Where do you see it? Sorry.
where it says suicide assessment. There's only 4 pages for October 31st. Well, actually, there would be 8 because it's 2 sides.
So that is the assessment that you go through. If somebody reports any thoughts of suicide, then you ask those questions, which go into a lot more detail about them.
So here you have a patient who's already reported to you as a psychiatrist that she's got suicidal ideation, worried about suicide, worried about killing herself days before October 31st, and a suicide assessment was done by McAllister, right?
I wasn't there. You would have to ask her.
Well, maybe I will if she comes in. Why don't you tell me what the record shows? Did they do a suicide assessment? Did she check off the little boxes?
I'm looking for that section. It says that patient denies suicidal or homicidal ideation at this time.
Okay, so again, this is on October 31st, right?
Yes.
The patient, within a period of a couple of days and meetings with you, that McAllister has access to because the records are within your business, right?
It's not my business, but yes.
Has reported suicidal ideation and fear and dwelling about killing herself and afraid of those thoughts, right?
I just want to be absolutely clear. So,
Yes, the
while
answer is yes.
earlier she had voiced those concerns.
Right. So as a result of voicing those concerns, is it your understanding that McAllister did not do any of the suicide assessment questions because Lindsay reported that she wasn't suicidal?
It appears that she asked about suicide.
Right, you already told us that. I'm asking you about, excuse me, she's right.
Hold on. Answer this question. Go ahead.
Thank you. I'm not asking you, you've told us 3 times now that she says she was not suicidal when she spoke to McAllister. I'm asking you about the suicide assessment for the 3rd time. You see it in front of you?
Yes.
Okay. Can you tell me, did Lindsay answer any of the questions that were asked over the 2 pages, possibly 3, of the suicide assessment? Yeah, 3, done by McAllister.
I don't see anything written here.
So was there a suicide assessment?
I don't know because I wasn't there. I don't know what.
And you don't know from looking at the records, right?
From looking at the records, I don't see evidence of additional suicidal questions beyond asking if it was there or not.
So, the suicidal assessment, doctor, is in the medical records. It consumes almost 4 pages, does it not? Yes?
Yes.
Okay. And all of the questions, like asking, have you felt life is not worth living? Is death something you thought about recently? Are you dwelling on that? What leads up to the thoughts? What are the thoughts? All those questions, right? For 4 pages, right?
Yes.
And there is not one notation indicating that that test was ever administered to her on October 31st, correct?
But it looks like it was asked in other ways.
Yeah, okay. November 2nd. Oh, it was asked in other ways? Is that what the little checkbox where it says denies suicidal ideation?
Can I read something that she
You
wrote
have
down?
indicated repeatedly that she denied suicidal ideation, right?
Yes.
Okay. The suicidal assessment was not administered, according to the record that's in front of you, by McAllister, yes?
The additional suicidal assessment, yes.
November 2nd. Oh, by the way, as a psychiatrist, not a psychologist, you have the ability to prescribe medication, obviously, right?
Yes.
And that's what we talked about, the DEA number and all of that, correct, which you had for about a month, other than when you were a resident, right?
Yes.
So you're prescribing these SSRIs and antipsychotics and antitropics or whatever they are, and it's important as to the metabolism of your patient with those drugs, isn't it?
Yes.
Okay, keep your voice up. What does metabolism mean?
The body breaking down the medication.
So how is it that you can determine how the body of your patient is breaking down the medication that is in their brain and they're complaining about all of these symptoms? How, as a doctor, do you determine how the body's breaking it down?
We don't typically have any specific testing that we do to understand that.
How about a blood test?
It's not done for that.
It's not done for that, meaning a blood test is not done to determine the metabolism of your patient, of your medications?
Are you referring to genetic testing?
No, I'm asking about the metabolism. I'm not talking about genetics. I'm talking about the metabolism of the SSRIs in her body.
Okay.
You can tell that metabolism rate through blood testing, right?
Not in the way that you're describing.
Okay, what way would it be?
There is genetic testing that can give information about metabolism.
Like what?
It can talk about different enzymes that a person might have to suggest It provides information about the enzymes that a person might have the genes for.
Okay, so it provides the enzymes that a person might have the genes for. Forgive me, I'm having difficulty with that. What does that mean?
It's a little complicated.
Yeah, you don't expect a patient that's going through what she was going through to understand that, would you?
No,
Did you guys do the enzyme test?
they are not typically done.
Why?
Because, again, it's genetics.
Does
and-
insurance cover it?
Objection, just in the middle of answering.
Finish that answer and I'll allow a follow-up. Go ahead.
So it's not as simple as testing for an enzyme or not. You can test someone's genome, like we have the ability to test the entire human genome now, but which is great, but the clinical use of that is not there yet. So while we can test these things, it does not yield meaningful clinical information. So it's not commonly done.
What is the Cytopro P4-50 system?
That's one of the enzymes I'm talking about.
So the Cytopro P450 system talks about and tests for the breakdown of psychiatric meds in the blood, right?
It's not in the way that you're describing it.
All I'm
Doesn't tell
describing
you
it is that it's a
Hold
test.
on, again, one at a time. Finish the answer and then you can ask follow-up. Go ahead,
It just, yes, this is a test that is done, but it doesn't tell you what medications a patient will do better on. It's not useful in that way.
So what's it useful for?
I mean, I don't find it terribly useful.
How long has the Cytopro P450 system been in use in your field?
Sorry?
How long has the Cytopro P450 system been in use in your field, psychiatry?
Well, it's an enzyme in the body.
Well, I know what it is. I'm asking you about the system, the testing. How long have they been using that?
The genetic testing,
Yeah,
maybe
whatever
a few
it is.
years. It's very new,
Very new. Does insurance cover it?
sometimes.
Sometimes. So it is nevertheless a legitimate test to determine the breakdown of psychiatric meds in a patient's blood, correct?
It exists, yes.
It exists. Well, it exists, but you didn't use it, right?
It would not have made a difference
In what? In your opinion?
in her treatment.
Because you go by the checks in the checkbox and what she self-reports, right?
No, not just the checks in the checkbox.
Oh. In any event, tell me about the thyroid.
The
Tell me about the
thyroid,
thyroid.
it's an organ in the human body that regulates hormones.
And what, if any, import and impact do thyroid levels have in your evaluation of a woman who is in the throes of postpartum depression?
They don't.
What is the purpose of a test to determine the thyroid levels?
Well, you can test something like the TSH.
Well, I don't know what TSH is. I'm sorry. What is TSH?
Thyroid stimulating hormone.
Okay, thank you.
That's something that can be tested, typically by maybe a PCP, primary care, or endocrinologist if they have concerns about someone's thyroid function.
Were you aware of a study that was a major study that was peer-reviewed? What does peer-reviewed mean in your business?
That it was reviewed by other researchers in a similar field.
And the report or the article or whatever it may be has to be approved by the peers that are reviewing it before it can be published, right?
Yes.
And you'd agree with me that in the medical field, it's a big deal to have publishing articles on your resume, right?
Yes.
And how many articles have you published about postpartum depression, postpartum psychosis, anything?
I have published something, but it's not a full article. It's just a small thing.
Okay. Are you aware of the psychiatry magazine article dealing with, in 2021, thyroid function in postpartum psychosis, an exploratory study? Have you ever heard of anything about that, let alone read an article about it?
No.
Are you aware that there are studies that have compared thyroid function between psychosis with postpartum onset, PPO, psychosis without postpartum onset, PWPO, and normal postpartum? You aware of that?
No.
Well, you're supposed to be an expert, or you specialize, or you have an interest in treating women that have suffered from postpartum, correct?
Yes.
Have you written any articles at all about postpartum depression, anxiety, psychosis?
No, I'm not a researcher. I'm a clinician.
Have you read any of the articles, such as thyroid function in postpartum psychosis?
I've read many articles. There are thousands. I have not read that specific article.
Thousands? Thousands of articles on postpartum psychosis and the thyroid?
No, not on that specific topic.
So, when the Astor doctors are treating a person like Lindsay, it's your testimony to this jury that testing, whether it's blood testing or whether it's the Cytopro P4 testing, is not necessary because Jennifer Tufts doesn't think it's necessary, right?
It does not yield information that would influence treatment.
Really? So if there was elevation in the thyroid, that wouldn't impact on your treatment at all, your evaluation, your investigation?
Sorry, I thought you had mentioned the cytochrome issue. Are we talking about that one, or are we talking about the thyroid?
We're talking about the thyroid.
Okay.
Yeah. So if there were tests that revealed elevation in the thyroid level, is it your testimony that you wouldn't care?
If I somehow found out that a patient had elevated thyroid levels, I would advise them to talk to their primary care or maybe get an endocrinologist to discuss it.
Did you ever recommend that Lindsay get an endocrinologist?
No, she
And the
did
reason,
not.
the answer is no. And you basically did not have any information that you could use to even realize that there might have been a thyroid issue with this woman that was postpartum, right? Because you didn't do any blood tests.
There was no clinical reason to obtain a blood test.
All right, so you continue on with your meetings by the computer, correct?
Yes.
November 2nd. You can get November 2nd out. You got it?
November 22nd?
No, it looks like November 2nd. I apologize. That's what I'm looking at. Tufts, Jennifer, MD, Clancy, Lindsay. Follow-up note, November 2nd.
Yes.
Okay. And you're still diagnosing her with generalized anxiety disorder, GAD, right?
Yes.
You add in there an adjustment disorder with depressed mood, I guess because of what she had been telling you, right?
Yes.
Okay. Looking at the psychiatric condition, you note that it's improving. Right?
Yes.
And then you determine that you will decrease the Ativan to 0.75 milligrams for 2 weeks, and then decrease it to 0.5 milligrams for 2 weeks, and consider alternatives for sleep anxiety. Is that correct?
Yes.
And then you note if she's having urges to harm herself or others, to go to the nearest emergency room and call 911 and things of that nature, correct?
Yes.
So is that a form that you basically press a button and it because it seems to be kind of like a generic advice. Call 911 if you're feeling suicidal and things of that nature.
Well, that's advice that we provide for every single patient.
Okay. And then you note that half the encounter was on counseling or coordination of care on November 2nd, right?
Yes, that's a typical statement. It's just a part of documentation that doctors use.
All right. Now, on November 2nd, you were suggesting the 4 drugs that she would start would be Remeron, Trazodone, Pregabalin, and hydroxyzine, right?
Those were just things we were considering.
Oh.
I wasn't starting all of those medicines.
I see. On November 22nd, now that would be almost 3 weeks later, right? You saw her, right? And did you ask her about whether or not she was still having suicidal thoughts or worrying about suicidal thoughts, for example? Did you ask her that?
Yes,
And how do you know that? Because the box is checked?
it's written in my note.
What does it say?
Patient denies SI.
Okay. What did you ask her about that?
I don't remember the exact words, but I know that I asked about that.
Did you ask her about how things were going at home with her mother and father staying there?
That I don't remember. I didn't document how her parents were doing.
Okay. Well, I don't really care about how her parents were doing. I'm asking about whether or not you asked her how it was working out while her parents were there helping out. If you did, fine. If you didn't, that's fine too.
I don't think that I did. In this
Okay.
appointment, she
Okay. That's all. That's fine. December 1st was the next appointment, correct? And you can look at the interval history.
yes.
Now, on that December 1st appointment, this is after she had transferred to South Shore.
Yes.
She disclosed to you that she had been seeing South Shore, right?
Yes.
We already talked about the fact that you never got the records from South Shore, so you don't know, other than what Lindsay reported to you, what medications she was on, right?
Right. I knew what she was telling me.
Right, and she told you that she was doing the Ativan taper, right?
Well, she said she had tried doing that, but that then she was having more sleep.
Having difficulty sleeping is what she indicated to you, right?
Yes.
And she tried other meds that you had suggested, but stated that she was having difficulty with those meds, including Trazodone, right?
Well, the trazodone she didn't have a problem with. It just didn't seem like it was particularly helpful.
Right. Did you prescribe the Trazodone or somebody else?
This was somebody else.
So, do you know what the milligrams were that she was on?
It says she tried between 50 and 150 milligrams.
All right. Now, did she at some point try Remeron?
She said that she did.
Did you suggest in your discussions that she try Remeron?
No, I did not.
Did she indicate to you that she had rebound anxiety and intrusive thoughts, that she was going to die? Do you recall that?
Well, she said worse depression and intrusive thoughts.
Okay. Did she tell you what the intrusive thoughts were?
It was the feeling like I'm going to die.
Did she then have a script for Prozac, 10 milligrams?
That's what she said.
And she said that she couldn't sleep and had worse sleep, so that had to be stopped, right?
Yes.
She had, then she tried. She was on Klonopin, right?
Yes.
And what is Klonopin?
It's a benzodiazepine.
And on December 1st is when she told you, again, that she was close to having suicidal ideation, feeling hopeless. Do you recall that?
Yes.
Now, on the interval history, on that date, you indicated that she can't sleep, she's panicking, she had worse depression, intrusive thoughts, she was numb, nothing mattered, I feel like I'm going to die. Denies suicidal ideation, but, quote, yesterday, close to it, feeling hopeless. Did you give her therapy and validations after she told you that?
I did.
What did you do? You got a woman that's telling you that she's hopeless. She doesn't care if she dies. Can't sleep. What did you do to validate on your therapy?
I told her that this was something that we could address, that there was hope, that there were treatments, and there are different types of treatment programs that are more supportive, like partial hospitalization programs. So she knew that she still had options and a reason to hope.
Did you ever suggest to her that maybe you ought to come in to see me rather than talk on the computer?
Talking with her over the video did not seem like an issue. It didn't seem like there was anything that I was missing or that there was any need to see her in person.
Now, you'd agree with me that in December of 2022, COVID was all done, right?
It wasn't completely all done.
Were you still nervous about dealing with people and wearing masks and stuff, or were you able to sit down and talk to somebody face to face?
We were definitely feeling more comfortable about being face to face with people, but I think, it was still something that we thought about.
You discussed trying Seroquel with her at that point, right?
I didn't really discuss it. She had told me that was something that she had discussed with her other provider.
So, looking at your notes, does it say also discussed trying Seroquel alone tonight? Did your notes say that?
It says yes,
What is
but
that?
I wasn't making a recommendation about the Seroquel. It was just a medicine I was providing her more information on.
So you were telling her about the Seroquel? You're providing information?
Yes, we were talking about the Seroquel.
Right. Why?
Because her provider had recommended that she start it.
What is Seroquel?
In case I got it.
You also discussed with her the possibility of undiagnosed bipolar disorder, did you not?
It was discussed.
And undiagnosed bipolar disorder was, in your opinion, as a result of not a reaction, but extreme reaction to the SSRIs, right?
Not as a result of the SSRIs, but that
Does your note say, and I quote, also discussed possibility of undiagnosed bipolar disorder given extreme reaction to SSRIs and insomnia, period. Does it say that?
Yes.
Those are your notes, right?
Yes, the way you were saying it made it sound a little bit different before, but that's exactly what I wrote.
I read it directly from your note, right? How did I make it sound different?
I don't know. It sounded different the first time you said it than the second.
So did she have bipolar?
No.
Did you make that decision that night? That day?
I assessed that with her pretty much every time that I saw her, and she never had mania.
What about mood stabilizer like Lamictal? Did you discuss that with her?
Yes.
What is Lamictal?
It's an anticonvulsant, but it's used in treating mood disorders.
So what was the end result of your meeting with her on December 1st? What did you guys do? Did you give her any recommendations, advice, anything?
Yeah, well, so at this time I was
Not prescribing her medications, but I was still concerned, not concerned enough that she was at imminent risk of hurting herself or anybody else, given what she said. But we had a plan for her to pursue a partial hospitalization program.
Where was that?
Well, the one that I had recommended was HRI.
What is that, HRA?
It's a hospital in Brookline.
And did she ultimately go to another hospital?
She ultimately went to the Women and Infants Hospital for 1 day.
And those are the records that you didn't get, right?
Correct.
Okay. And you decided that she did not have bipolar disorder because, in your opinion, she did not meet, and I quote, the criteria, right? And that would be the criteria in the DSM, right?
Yes.
And the DSM, of course, is the Diagnostic Statistical Manual, Roman numeral 5, next revision, right?
Yes.
Is that what you were using back then? Would be this thing here, DSM-5, TR, this is DSM, right? It's like a cookbook, right?
It's more of a guideline that we use to.
To help us in our treatment, but it's not the psychiatry Bible that people sometimes think that it is.
Right. Hypomanic bipolar disorder. How many days does that require under the DSM?
A hypomanic episode lasts for at least 4 days.
And is that per the DSM?
Yes.
Remember on Friday you said that the most important criteria is 7 days with continued high energy levels?
Yes.
So is it 7 days or is it 4 days? And who says?
Well, mania is 7 days. Hypomania is 4.
Discussed again, Monday does occur on December 1st, and that would be the Lamont sheet, right?
Yes.
And do you know in your records that she indicated that she was really struggling? And it was as a result of that that you recommended that hospital program, correct? Would you agree that she had, in your opinion, a severe mental disturbance at that point that was manifesting itself?
She had maybe moderate heading towards severe.
Moderate, heading towards severe mental issue. Okay. You'd agree with me that she had increased anxiety, right?
Yes.
She had very, very increased depression, right?
Well, she did. She said.
Okay, so as you answer
since
yes,
the-
can you just answer yes or no?
I'm sorry, I was just trying to check the record.
Okay, you can check the record all you want, but if I ask you a question respectfully, can you just not go on and ramble? Answer yes or no, that's all.
It's sometimes impossible to do that.
All right, you tell me.
Here, if you can't answer yes or no, just say you can't answer yes or no. If you can answer yes or no, answer yes or no. That's how we do it, all right?
Okay.
Thank you. Now, mental issues like anxiety that was diagnosed, the depression that was diagnosed, and the fact that she indicated yet again that she was close to suicidal ideation, quote, worried about suicidal thoughts, but you indicated that she wasn't suffering from suicidal ideation on that date. Is that fair?
She denied it.
But she told you that she was worried about suicidal ideation and having suicidal thoughts, right?
Well, this was the time she said she was worried that she was close to having suicidal thoughts.
So did you ask her what does that mean? Does that mean that she's standing at the edge of the stairs and she's thinking about falling down the stairs, or what? What does that mean? I'm close to suicidal ideation.
So I asked about that, and that's when she said she described it further as using the word hopeless.
So did you prescribe the lamotrigine on that occasion or no?
No.
On December 16th, that's the next appointment she had, right?
Yes.
That'd be 2 weeks later, right?
Yes.
She was still not well, correct? She told you she was having a really rough time.
She was sleeping, but she was still feeling very poorly.
In your notes, does it say that she was having a really rough time?
Yes.
So when I asked you, If your notes reflected that she said she was having a really rough time, why do you feel compelled to say she was sleeping?
Objection.
It's an important detail.
Yeah, I guess. How about the rough time? What did that mean? What were the symptoms of having a really rough time for this kid?
Do you want me to?
Yeah, I'd like you to answer that.
So finally works, referring to the valine-quetiapine, but very depressed during the day, no motivation, some SI. Do you want me to continue?
Sure.
Went to MGH emergency room for SI,